So I'll go quick on the last presentation, which is a collection of some interesting things we've been doing in the clinic. Okay, so the last talk is about some updates on hair, some laser, and skin cancer. And androgenetic alopecia is such a common problem, and there are so many different treatments given left and right, but there is, of course, like a scientific, evidence-based approach, which I think all of us dermatologists are aware of, and it's very important to combine it. Monotherapy is always usually a waste of time unless someone is really early on, a 17-year-old who's coming with early androgenetic alopecia. Important to rule out underlying disorders, PCO, deficiencies. We usually recommend minoxidil only at night to improve compliance. When you use it twice a day, you increase the risk of side effects, of fatigue. We give oral supplements, especially in women, to restore their needs for biotin, vitamin D, iron. We do PRP, exosomes, microneedling, red light, and different approaches. I always try to prescribe oral 5-alpha reductase at half the dose. Spend a lot of time discussing that with my patients. I think half the dose would still work and reduce the risk of any side effects, sexual side effects, which are often placebo, to almost zero. We like giving aldactone as well in women, and we like to recommend hair transplantation when it's time, when medical treatment is no longer helpful, and combine always with medical treatment to maintain the hair that is native in the area. I really think that androgenetic alopecia being a miniaturization process, one day science should allow full reversal and deminiaturization, but we're still not there. It's been such a slow process, but we're not giving up. PRP is a mainstay of treatment of hair. It has really changed our practice. A two-step centrifugation, I personally add nothing. I only use the red tube and the blue tube. It gives that nutritional boost derived from the platelets, and it has an anti-inflammatory effect. We like to do deep intradermal injection or like barely superficial sub-Q, and sometimes combine with microneedling. And with regular use, studies have shown that it increases the density by close to 25 hairs per centimeter, which is great. This is a patient with long-standing, alopecia, most likely from some unusual alopecia areata here. With a single session of PRP, I never expected that. She had a great result. She had that for years. Microneedling, invasive, aggressive, it has to lead to some bleeding because you need to go to about 1.5 millimeter. Needs to be done with a ring block. We do it not so regularly, but sometimes we do. It requires a ring block, and the studies have shown improvements with alopecia areata, in addition to androgenetic alopecia, just like in this case, that was combined with PRP. Exosomes, still, we've tried them, we use them, I find them effective. They're still not FDA approved for deep injection, only as application on top of microneedling. They have a signaling role in getting that cycle going well and faster, and in some assessments it might work better than PRP. Till now, I personally prefer PRP because of the safety record. Biosomes being synthetic exosomes might be something interesting in the future. We are testing them in the clinic to see their efficacy. Botox has been reported to be effective in androgenetic alopecia, and the idea is that there is some muscular tension in the scalp that prevents proper vascularization of the follicles. And by relaxing the muscle, there is better blood supply and good regrowth of hair. I've done it a couple of times. I do so much Botox for rejuvenation that I don't want to do it for hair. That's my personal bias. But I think there is some merit to doing that. And of course, light biomodulation, producing ATP, is synergistic with other treatments. It helps to give patients, a recommendation to use it at home. There is data that it helps. But when it stops helping, all these medical treatments, or when people come in and they are at an advanced stage, of course, the hair transplantation is the way to go. And that has been perfected pretty much in a very nice way. We came a long way from the strips and small sessions to FUEs and really large sessions where, we are able to transplant close to like 2,400, 2,500 grafts per session. And when we do 2 sessions back to back, we can reach close to 4,500 safely. It's easy to do more if you have the team and if you have the time, but you would be damaging the tissues a lot with your FUEs, extraction sites, and with packing too much. The hairline, it's important. It's a signature, as you can see here. Doing things very carefully will allow someone to present themselves to someone new under a spotlight and never be known to have a hair transplant done. And that's the art of what we do. The patient, Norwood type 6 or probably 6 with good reconstruction, that looks pretty much, quite natural. It's hard to make them look extremely natural, but it's not the hairline that is straight, that is too low, and that is important. A younger man with a transplantation, this one was done robotically, but it can be done the same manually. I rarely use the robot now because we're much better and faster manually. But this is obviously life-changing. See how the hairline is natural, retaining the receding temporal area is very important for a natural result. And having gray hair is always a plus because you don't see the contrast. Many times we don't have to shave the whole head, especially when men or women have long hair, and we just shave that rectangle in between the hairs and transplant, without shaving hair. And that's a plus that we can do in the clinic with the techniques that we have developed over the years. Beards have become a huge thing for so many men, and so many present to reconstruct their beards, and that's something we can help with in a nice way. Personally, I'm looking forward sorry, Dr. Rami, for this trend to pass. Bad work everywhere in the world. Everybody who has, wants to make money on hair transplantation. So you see really bad hairlines. You see extremely dense hairlines where the hairs do not grow, or so much is done that there is, necrosis. And I don't have this picture in this presentation of necrotic areas in the scalp due to extensive packing of grafts. Here's someone who had a poor job, as you can see, and we ended up, my team and I in Beirut, we did hair removal laser. Imagine, he had a hair transplant that we had to remove with the Alex laser, and then retransplanted some hairs to give him a more natural hairline. The depletion in the donor area happens when too much is removed to try to do a great job at the top. It's always a balance between keeping a natural hair density in the back, especially if someone carries their hair short, and doing a good job on the top. And talking about beards, they are a good source of extra grafts when we are getting near depletion. And this is an area that heals well in a few days and leaves no scars with the punches that we use currently. Women need a hair transplant as often, not as often, but as importantly, if not more importantly, than men who can shave their head. And this can be done with really the experience that one can develop over the years to go in between the hairs and protect the existing hairs, yet transplant the hairs in between. This is an example of what we can achieve. Here's another very nice example of a 60-year-old lady whose dream was to have a transplant, and she had it done, and as you can see, only the transplant and minoxidil after 1 year. Eyebrows, we still haven't perfected eyebrows, but we can do an okay job. The hairs need to be, I call it landscaped, trimmed over time because they would grow as we take them from the scalp. We take them from the lower part of the occiput where the hair is finer, but still they would continue to grow for life. Patients with lichen planus pilaris or frontal fibrosing alopecia, whose problem continues over the years and still is for which the cause is not known, we can transplant them when they are more or less stable. And if they lose the hairs, we can always transplant a little bit more, but it will help them have a better density for years. Skin cancers, this patient has a typical crateriform basal cell carcinoma on the nasolabial form, fold, and the typical hyperkeratotic squamous cell carcinoma on the upper lip, a smoker, skin type 2, cooked in the sun. The best treatment is Mohs micrographic surgery because it allows us to do the pathology on the bedside while the patient waits. We examine the whole margin of the skin, and so we are able to locate any residual cancer cells. If there are any, we go back, take them again in a second stage or a third stage. We do this at Skin Experts. We're the only center that does this technique properly and in a fast way, because others might do it in a slow way. So not only we have the margin control and reduce the risk of recurrence to around 1% with first-time basal cell carcinomas or squamous cell carcinomas, the percentage recurrence is a little bit higher in recurrent lesions, but we also have tissue preservation, so the scars are smaller. And this technique is ideal for basal cell, squamous cell, but some cases of lentigo maligna, fibrous tumors, and angiosarcoma. There's some of the nice results I've done over the years. A post-BCC Mohs on the nose, repaired with a bilobed flap. A recent case referred to us from Abu Dhabi, a patient who has a morphiform basal cell on the whole nose, and as you can see the defect, because we were on bone, we allowed the defect to granulate for a week and then grafted it from the clavicular area, and you can see the nose healing very well at 6 months with no recurrence. It's important to do Mohs in these patients because if you remove the skin cancer blindly here, you might remove too much and give the patient a huge defect that will require very complex reconstruction, or you might not remove enough, do a nice repair like this, and then see a recurrence at either under the graft or on the margin and have to redo it again, which is a disaster. Mohs is highly recommended on critical areas like the nail bed, as in this case, where a skin graft was done, or the penile area. I've had 2 patients in the last few years develop them with HPV viruses nearby. Lasers are effective when tumors are superficial and very large and not amenable to surgery. This is a vascular laser. The alexandrite we think of it as a pigmented laser, but it also is absorbed by oxyhemoglobin, and we've been able to clear this tumor in 2 sessions. High energy, no cooling, no recurrence for I think a year I have, and then I lost that patient to follow up. Here's a patient who had radiation therapy for his face for acne when he was young, and ended up having these pigmented multiple basal cells on his face, treated with the Alex laser, resolution, no recurrence for as long as I was able to follow him. So lasers are used as a good palliative choice when available, either for very small lesions on like non-facial, or very large one on non-facial, that as long as they are superficial. Relatively quick healing. Sometimes they take a couple of weeks to heal, generally with minimal scarring. So for lesions that are vascular rich, we choose the vascular lasers. Pigmented lesions, we use the alexandrite laser. 1 to 3 sessions, it's usually fine, and we sometimes combine with PDT, 5FU, or other ablative lasers. Keratoacanthoma, when you are sure of the diagnosis, and that usually is quite typical, very rapidly enlarging tumor, causes major anxiety, and we're seeing an epidemic of KAs lately in the clinic, sometimes in this case occurring on the face of a young lady in her early 40s. With all the experience that I have, And because I was certain that this was a keratoacanthoma and the pathologist confirmed this, I was comfortable to inject her with methotrexate. And you can see after 4 sessions, we were able to clear her. And this is from at least 7 years ago. And now I see this patient in the clinic, still no recurrence. This is a study showing how well it works. The endpoint of using methotrexate is using the 25 milligram per ml. You inject to an endpoint of blanching. And if you do it on lesions that are biopsy confirmed and where the clinical manifestation is consistent with the KA, because the thing is to separate from an aggressive SCC. Of course, you don't want to treat an aggressive SCC with keratoacanthoma. And Mohs would be more indicated. But if you're sure of the diagnosis, to me, this is the go-to treatment now. Here's a patient from a Pakistani patient who was referred to me from here in Dubai, for Mohs, and I felt that, as tissue sparing as I can be, and with all the experience that I have repairing, and even if I have one of my plastic surgery colleagues help, I thought, because the tree looked like a KA, it evolved within 3 weeks. He is skin type 5. He's not the typical SCC patient. So we went for the for methotrexate treatment. He was very anxious. I think he was. He stabilized in the beginning after 2 sessions. On the 3rd session, he was kind of panicking. We decided to add acitretin. I think on the 5th session, it was gone. And this is him a year later. Removing onto congenital melanocytic nevi. A lot of these nevi are, of course, every large nevus has a higher risk of melanoma. The risk now we know is not so bad, but in this case, the removal was more for aesthetic purposes. And in order to have the nice scar that I was able to obtain after surgery, I did a 2-stage procedure so that we were able to keep the length of the scar shorter, and the result was really nice with like a session of laser afterwards to polish the scar. But I want to pose a dilemma here. When we see patients with giant congenital melanocytic nevi, which can occur 1 in 20,000 births, and we're defining them as 20 centimeter in size or bigger, like this child who a few years later came to me. So I have this picture from his soon after he was born. So the concern with giant CMNs is the neuromelanosis, and the melanoma risk is within these CMNs is about 8%, and if it is larger than 40 centimeters, it's 12%. So does that justify disfiguring surgeries or not? And that's the controversy and the debate. I think it should be always a case-by-case study, but the surgery can be extensive and cause a lot of hardship for the family. When there is CNS melanoma, this is really bad news, and the fatality rate is 100%, and no chemo really works for this. So it has a huge psychosocial burden, and I think laser has something to do here. This is a young man that we saw like a year and a half ago at the clinic, and you can see the huge scar that he had. His family and him spent years in Europe getting surgeries, balloons to expand the tissue, to get most of the CMN removed, and still he had some at the border. But you can see he's it's hard to walk around like this with your friends and you have an eye. So the residual scarring is quite extensive, and you just wonder if it was really necessary to do this. The same boy, we did hair transplantation on him, and this is him. He sent a picture because they moved to Europe since we did this. But I want you to know that what we can do for these CMNs is like we did with this patient here, young girl at the school in South Lebanon who was actually bullied by the principal at school and was told to never come to the school. So we treated her. with a combination of erbium and a pigmented laser. I think here after 8 sessions, and you can see that we can do a really nice job to lighten these CMNs. Of course, on the left, it will be hard to cover it with things like Dermablend or CoverMark, but on the right, it becomes a lot easier, and it really reduces a lot of that burden of what's going on. Till now, there is no evidence that laser can trigger melanoma in any CMN with all the ones that have been treated. To the best of my knowledge, and I try to be current with that information. But we need to know is that if a melanoma is going to arise, and it would probably have arisen anyway, and not sure if that it was triggered by the laser, it would be most likely an amelanotic melanoma, and that's something we explain to the patients. I spoke this morning about Accure laser, the new 1726 nanometer laser that is specific for sebum, so it has an affinity for the sebaceous glands, while no damage is done to the surrounding tissues. This is a new laser that is a game changer for acne that provides high energy in a boost mode to heat the oil glands to about 60 degrees. That's a lot of temperature, and almost, I wouldn't say cook the oil glands, but it makes them quite inactive for a long time. And it gives you that effect of isotretinoin with a laser, while there is cooling all the time to protect the epidermis and the surrounding structures. This is a pathology section of the sebaceous glands damaged by the 1726, and you can see that the epidermis and the collagen and the rest of the dermis was spared. So it's very specific to the oil glands, and the results are fantastic. Putting a few studies together, with a single treatment, there is a reduction in inflammatory lesions count of between 29 and 45%. When 4 treatments are done, the reduction is up to 90%. And after 3 months of the last session, after typically 3 to 4 sessions are done, 90% positive patient satisfaction. You can see the results that are achieved with this laser in one of the larger studies that has the longest track at 52 weeks, basically 1 year. You can see that the inflammatory lesion count reduction was at 90%, and this is very important, with no adverse effects that are to be mentioned. So I hope this was a good workshop for everybody. Thank you for staying late. We'll take some questions. I want to thank the team, Dr. Dora, Dr. Zainab, Dr. Rami, Dr. Narwan, Dr. Brahim, Dr. Ali, who has helped a lot with much of the work that we do and with preparing these talks as well. So thank you for your attention. We can take questions if you like. Thank you for staying long. Sorry we went far, but we knew nobody was going to be after us, so we let the speakers take their time. Thank you again.